Hey guys, we're going to be talking about oncology today. Now, as you guys see in your book, there's not a huge wealth of information on oncology. So obviously we're not going to be covering just this huge mass of information on it, but we're going to hit the high spots and we're going to talk about it. If you guys are going to be oncology nurses, then obviously you'll have some additional and specialized training in that. But we're going to hit what you really need to know about oncology, some of the things that we're going to talk about. Now, I did want to add in a couple things while I was thinking about it. I think that I covered them all, but I wanted to say it again. So just in case I didn't cover it when I was doing the lecture for pre-op and post-op. Now, the herbal products and surgery that you're going to be worrying about, I think that I covered them all, but I wrote myself a list to make sure that I said them all and didn't forget one. So St. John's wort, black cohosh, feverfew, valerian root, fish oil. I think that I've got all those covered. So I wanted you guys to know that those are some of the things that that you need to make sure and see if your patient's on. Now, statistics. I went ahead and put that on here because I really like to do statistics so that you guys can see how prevalent cancer is. I mean, the American Cancer Association, this was in 2008, estimated that 1,437,180 new cases of cancer would be diagnosed that year. Now, things are changing. I mean, we're doing more research. We're spending more money. We're trying to figure out, of course, obviously we've mapped the genome. That's helped us a lot with cancer, trying to figure out, like our BRCA genes with our breast cancer. So there have been improvements that have been made, and death rates have decreased some, 1.8% in men and 1.6% in women. So, I mean, that's better, but we've got a long way to go, because when you think about it, cancer is going to occur in about 1 in 3 people. Now, 3 people standing line to line. If you've got a long line of 3 people, let's just talk about your class. Let's line you guys up. Think about how many of you guys are going to have cancer when you think about it that way. Line your family up, because this is a tough one to talk about. 1 in 3. Those are crazy, crazy numbers. So I want you guys to think about this in those terms. It's crazy how prevalent cancer is, and so that's the reason why it's important to talk about it. Now, I went ahead and put a slide of definitions in there for you guys so you can see the difference in incidence and prevalence and mortality and survival, so that you guys could see those in definition form. It's always easier to understand. You hear incidence rates, and unless you really look at the definition of it, it's not necessarily as clear. So I went ahead and put those in there. I also put a slide about proliferative growth patterns in there so that you guys could see. Now, when we're looking at the non-neoplastic side there on the left, we start with hypertrophy, and then we go down to hyperplasia, metaplasia, dysplasia, and anaplasia. Now, as we go, these cell changes are, they get worse and worse as we go, right? Now, we talked about hypertrophy in the cardiac lecture, right? So, I mean, that's not a cancerous change, but it is a change in a cell. It increases in size. So as we go down, we've got, cell changes that are conducive to, cancer changes. So I wanted you guys to know the difference in them, because you will be seeing path reports and things as you go along in your career, and that will help you get a gauge on the differences in them. Now, when we're talking about dysplasia, those cells are altered. Now, there's, most of the time it's because of an external stimuli, radiation, inflammation, a chronic irritation, a really good one, intoxic chemicals, but a really good one that I always think of with the dysplasia is in some of the gynecological cancers. That's a big one. When we're talking about metaplasia, um, that's a really common one. If you've ever heard of, which we talked about it, Barrett's esophagus. That's one of those things where one cell type is replaced with another cell type, and cancerous changes can occur because those cells aren't meant to be in that spot. So, just think about these things as we talk, and you're going to find them. Obviously, we've talked about cancer in each section. We talked about gastric cancer when we talked about the GI system. So we have talked about a lot of cancers along the way. So you guys are going to be having to pull some of the knowledge that you've gained this whole time as we talk. Now, I do want to say something when we're talking about, since we're talking about cancer. Now, I want you guys to think about cancer. Now, some cancers metastasize, right? And they travel and, spread someplace else. Now, if we've got somebody that's got breast cancer initially, and it spreads, let's say it goes to their lung and then it goes to their bone. It's breast cancer that they have. It's just metastasized. If it's a primary, if it was lung cancer that went to the bone, then it's lung cancer that's metastasized to the bone. Typically, when you've got a patient with bone cancer, it's not because they have bone cancer most of the time. It's because it has traveled from someplace else. So I want you guys to think about cancer in those terms. It's always really important to find out where it came from so that we know how to treat it. So that's something that we're going to be talking about as we go along the way. Now, certain cells, it doesn't matter how old we are, they're going to continue to grow, they're going to continue to divide, all of those things. Just think about it. As we get older, we get the hair. Well, we lose hair in some spots, but we gain it in some others. We've got ear hair and things along those lines. Ears continue to grow. Hair continues to grow no matter how old we are. So when we're talking about cells of the skin and hair, the mucous membranes, the lining of our organs, and bone marrow, those are continuous. Those are going to divide throughout our lifespan. I want you guys to think about, our skin. It sloughs off all the time. We lose a huge amount of skin cells. And then, think about it. If you're constipated and you have a stool that scrapes the inside of your colon, it's going to replace it. So, that's normal cell growth. Now, cells of the heart, they stop growing by cell division during fetal growth. Now, heart cells can, we talked about hypertrophy. We talked about the hypertrophy, the cells increasing, they getting bigger with certain heart conditions, and they can grow in size. They can grow in size and they can grow in number. Sorry about that. And that is the hyperplasia. But the heart doesn't grow by any other means. After that is complete, we're done. It's one of those things. So certain things don't, like the heart, but certain things do, like the skin, the hair, and all of the lining of our GI tracts. Those keep on producing more. So, now, cancer cells come from normal parent cells. That's I know that's hard to think about, but cancer cells, come from a normal cell. The processes that control the normal cell growth and function are the parts that break down, and they lead to these abnormalities in growth. So, just something has gone awry. And, we talked earlier about some different things like, a person may have been exposed to asbestos and then now they have a lung cancer. There's different things that cause this to happen, but they do come from normal cells. Now, let's switch over to the characteristics of cells. Now, I put those on there so that you guys could see a side-by-side of normal cells and cancer cells. Now, remember that apoptosis is programmed cell death. I went ahead and put that in there for you guys in case you did not remember. Now, cancer cells, the thing about them is that, of course, they're growing, they're getting larger, they're putting pressure on the surrounding tissues because they're growing beyond their normal margins. So I want you guys to think about that as we talk. And, we're going to talk more about that in a little bit. I went ahead and put the carcinogenesis slide, and I should have probably put it up in front of this last side by side, but I didn't. So I'm going to backtrack a little bit. Now, carcinogenesis, it used to be called oncogenesis, and cancer development. That's what that stands for. And that used to be something that we used to call it back in the day. So I'm trying to get in the habit of saying carcinogenesis instead of oncogenesis. So bear with me if I say the wrong thing. I don't mean to. So when we're talking about this, malignant cells, cancer cells, there's nothing useful about them. They are abnormal. They don't function right. They harm the body. So there's nothing good about these cells. Malignant cells, what happens with them is they re-enter the cell cycle more frequently. So what's happening is, normally we enter the cell cycle, it does its thing, it's done. But this keeps re-entering, these malignant cells keep re-entering the cell cycle more frequently, and so cell division is a continuous process. So we have this malignant cell that keeps dividing and keeps dividing and keeps dividing. So what does it do? It gets bigger. So that's the issue with these malignant cells, is it does not want to pull out of the cell cycle, and it just keeps growing and growing and growing, and of course until we do something about it, whether it happens to be take it out or try to shrink it with some radiation or chemo, or radiation and chemo, however, depending on the case. So anyway, yeah, I'm not going to go into generation time and all that, but anyway, I do want you guys to think about this. It only takes one cell to begin a cancer. It takes one cell. So, it makes me really nervous when somebody says, I'm cancer free. I had this mastectomy and I'm cancer free. All it takes is one cell to start the whole process off. Even if you've taken it out, just one cell escapes and it gets on your scalpel and touches something else, then you've got a worry. So always makes me nervous because it only takes one cell to start this off. Now, we talked a little bit about some of the factors that influence cancer development. I want you guys, when exposure to carcinogens, the first thing I think of when I look at this is asbestos, because you see all of these lawyers coming on, and if you've been exposed to asbestos, please call us. Asbestos causes lung cancer. Hairdressers, which of course now we've changed some of these chemicals around after we found out that they are carcinogenic. But hairdressers had a lot of bladder cancer. So they've tried to change that around, so, to protect that population. So there are a lot of carcinogens that we're exposed to that can cause cancer. Of course, tobacco use is a big one. 30% are related to tobacco use. So, that's the reason why it's really important. I know that 30% may not seem like a whole bunch, but when we talked about the statistics and how many people do have it, that's a whole lot of people. And of course, we're doing campaigns and things trying to cut down on, patients using tobacco and things. So just keep pushing that to your patients. Of course, genetic predisposition. We talked about the BRCA1 and the BRCA2 genes, and those women that are positive for those genes, they have to worry about breast cancer, and of course, the female cancers as well. Most people who have that family history. Angelina Jolie is a prime example of that. So she kind of, being high profile, kind of put that out in the news a little bit more and let people know a little bit more about this genetic component to cancer. There are families with familial polyposis. They have crazy colon cancers at very young ages. So there are certain genetic predispositions, and so if you've got a family history for that, you need to be aware of that and be watching closely. going and having mammograms and doing breast self exams and doing colonoscopies and all of those things that we can do as primary, secondary, and tertiary prevention, which we'll talk a little bit more about in the future. But I want you guys to be thinking along those lines. Now, immune function, our immune system can protect us from cancer. It is made to do that. But if our immune system is crappy, whether we've got AIDS or we've had a heart transplant or we have, there's a lot of things. I always think of our patients that have Crohn's disease and all of those things. They're on medicines to knock down that immune response. So, they're at a higher risk for these things. So anytime you've got a patient with an immune function, age is a big one. Remember, we talked about that earlier. We're really going to have to watch these patients because they're going to be more susceptible. Now, think about our HIV patients. What are they susceptible to as far as cancer? Kaposi's sarcoma is one of those big ones with them. Now, let's move on to cancer staging. Now, when we're staging, we want to know exactly where the cancer is. We want to know how much it has spread because that's going to help us determine what we're going to do as far as treatment goes. We use the TNM system, the tumor node and metastasis system, to stage it, and that gives us a really better picture of what we're looking at. Now, I do want to talk to you guys about benign tumors. Now, benign tumors, they're typically encapsulated, and they grow by expansion instead of invasion, right? Our invading tumors, there are cancerous ones typically, and our benign tumors typically grow by expansion, not invasion. Now, benign tumors still cause damage because they're pressing on these normal tissues, right? They're not invading them, but they're pressing on them and causing some, even if they don't harm what they're pressing on, they still can cause the patient a lot of symptoms. Now, I always talk about this because your brain is a really good example of a tumor that's benign, but you still have to go in and take it out. Now, think about our cranium is only so big, right? There's not much room for expansion in there. And if we've got a tumor, whether it be benign or cancerous, it's going to be pressing on things, and it's going to cause some really serious side effects or death for the patient. So I want you guys to think about that when you're thinking about cancers and thinking about, oh, well, it's just benign. There's no need to worry about it. Sometimes, yes, there is. So I'm going to get back onto the staging part. I just wanted to throw that benign tumors encapsulated part in there while I was thinking about it. And I saw the carcinoma in situ. And so anyway, we definitely need to talk about that a little bit too. Now, the carcinoma in situ. Now, these are still cancer cells, but they are in a localized area. They haven't invaded the basement membrane and gone out of that area and spread to another area yet. So we still have them in this one area. So, of course, that is always better news because it hasn't spread anywhere. That's common in the cervix, the skin, the mouth, the bronchus, the breast, and the esophagus. So when we're talking about staging, our goal is to catch these things as early as possible. That's why we do screening, and that's why we do all of these things. It's because we want to catch the cancer as soon as we possibly can before it has a chance to get big and spread and cause more problems. We've got a better chance at treatment and a better chance at a cure when we catch it early. And also, we have to stage these things so that we know how to treat them. So now the next slide, I put a cancer grading in there just so that you guys could see, if you're reading a path report and they've got it graded, that's kind of how they tell the cancer cells as opposed to the normal tissue that it came from, to see how much it has changed. Now, you're going to see some questions on your exam about the TNMs. And so I want you to, I've got a chart in there. I put it in chart form as well so that you could see some of the different staging examples. So I do have an example in there. The T stands for the primary tumor, the N is for the regional lymph nodes involved, and the M is for distant metastasis. So, if we've got a tumor and it's a T1, now it's small, right? But it's still detectable. Now, if we've got somebody with an N3, we know that there's 3 nodes involved, 3 lymph nodes involved. If we've got somebody with an M1, we know that it's metastasized to at least one site. So I want you guys to be sure that you know how to stage. So, just look at that and be comfortable with that. Of course, the higher the number, the more serious the cancer is, and the less treatable the cancer is, and the possibility that we might not be able to do anything about it arises at that point, right? Now, I put on there a matching section, and, again, these are prefixes. We talked about suffixes earlier, but these things will help you try to figure out the location of the tumor. So, osteo is bone, lipo, fat, all of those things. So I want you guys to just be, that's just more for your knowledge so that you can look at a word and go, oh, yeah, I know where that tumor is. Now, tumors spread by, different things. Now, of course, there's direct spread, and I put some pages on there for you guys to look at, and there's some charts showing you the commonly occurring cancers. Now, metastasis, I just listed it because there's not going to be a test question asking you about angiogenesis or cell invasion or things along those lines. But you look over that and make sure that that you understand it. But I'm not asking anything specific about that. Now, I did put a statistic from or a statement from Merkel from 2009 in here. It is believed that 1 in 10,000 tumor cells that separate from the primary tumor are able to endure long enough to begin the metastatic process. Now, we talked about earlier, it only takes 1 cell, and that is where I got that statement from. Of course, there's a lot of data on it, but this one actually was in your book, so that's the reason why I specifically used that one. Now, I want you guys to think about what a patient experiences with metastasis, and that's just, where it spreads to. Now, if we've got a patient that's had uterine cancer or a melanoma or bladder cancer, I mean, we can use many examples, but a lot of times these spread to the bone. If we talk about ovarian cancer, a lot of times it spreads to the lung. Now, the National Cancer Institutes, they have put out a list of where certain cancers typically spread. Now, it may not just be one thing, like bladder cancer can go to the bone or to the colon or, lots of different places, but a lot of times that's a pattern that you will see. So, you can go look that up if you want to see that, but I just wanted you guys to realize that there are certain sites that cancers go to. So, if we're assessing a patient, what are we going to see? I mean, if we've got a patient that's got bladder cancer, and we're treating them for bladder cancer, and then all of a sudden they go, oh my gosh, I haven't been able to sleep the last week. My back hurts so bad, or man, my leg has been killing me. It is so sore. Are we going to be thinking, uh-oh, I'm afraid this may have spread? Of course. The same as with ovarian cancer. If they've got shortness of breath or chest pain or something along those lines that's new, then we're going to be worried about metastasis. So I want you guys to be thinking along these lines as we go through here. Now, when we teach stuff, we're teaching you, more of the factual things. But you guys have to use you have to use all of this knowledge that we give you, and you have to think about it from the nursing process through a nurse's eyes with this critical thinking skills. So as we talk, I want you guys to be thinking about that. And I'll try to throw some stuff in here to help you think about that. But, I just want you guys to be thinking along the lines of, hey, if it's metastasized, we're going to see symptoms someplace else. Now, if we've got a patient that's got bladder cancer, but it's gone to the bone, well, what are we worried about? Do patients with bone cancer have a lot of pain? Oh, yes. It is a severely painful problem. Also, their bones become weak. We have to worry about, them falling and breaking something. Safety is a key with these patients. I've had many patients with bone cancer, and they don't like to be touched because it hurts so bad. So, what are we going to be doing for these patients? See, we're using the nursing process. Are we going to be grabbing them under the arm and pulling them up in the bed? No, we're going to be using that draw sheet and make sure that we're using that because that is more comfortable for the patient to use. If we've got a patient and physical therapy insists on getting them up and walking them to get them stronger to go home, are we going to pre-medicate them? Yes. All of these things are nursing things that we're going to do for these patients. So I want you guys to be thinking about the nursing process and what we're going to be doing for these patients as we talk. Now, I put a list of things, factors that contribute to cancer in there as well. I talked about asbestos and lung cancer. Now, HPV. Most people don't think about that as being a cause of cancer, but it's one of those things that we have to watch out for. Cervical cancer. Of course, when we see the sunlight, we know that skin cancer, hair dyes, that's one that I talked about, bladder cancer. Of course, tobacco is typically a lung, or if they dip, then it's going to be an oral cancer, oral or throat, mouth or throat cancer, head, neck. Alcohol is typically stomach cancer or liver or, those kinds of things. The ones on the right side, the low fiber intake, high intake of red meat, high animal fat intake, those are all going to be our GI cancers, our colon cancers, and nitrates as well. Nitrates, that's one that can affect stomach with GI. So, personal factors affecting cancer development. We talked about the immune system. So, that's going to be a big one. So as we get older, our immune system doesn't work as well either. So advancing age is really an important factor with all of this. Now, I liked this cancer's early warning signs. Change in bowel or bladder, a lesion that doesn't heal, unusual bleeding or discharge, thickening or lump in the breast or elsewhere, indigestion or difficulty swallowing, obvious changes in wart or mole, nagging cough or persistent hoarseness. Now think about that. Changes in bowel or bladder. Well, duh. We know that's bowel or bladder cancer. A lesion that doesn't heal. Of course, it depends on where it is. If it's in the mouth, then we got to worry about an oral cancer. If it's on the skin, just depending. Unusual bleeding or discharge, then that's, one of our female cancers. A thickening or lump if we're talking about the breast, then we worry about it as being in the breast. But, it can happen lots of places. Indigestion or difficulty swallowing, that can be throat cancer, esophageal cancer. Wart or mole, that's skin, nagging cough or persistent hoarseness. That can be, a lung thing. It can be a throat thing. Cancer of the vocal cords, cancer of the larynx, pharynx, all of those things. So, just be thinking as you see signs and symptoms like this as to what they can cause. Now, how do we prevent cancer? Now, we're talking about primary prevention, right? Those are strategies that we use because we want to prevent the actual occurrence of cancer. So, we're going to be doing our education on tobacco cessation. We're going to be, all of these commercials about asbestos, if I see a lawyer on TV saying, yes, if you've been exposed to asbestos, you may have lung cancer, that's going to clue me in that probably asbestos might cause lung cancer. I probably need to check on that. Of course, lifestyle modifications are a big thing that we can do. Our diet, alcohol restrictions, of course, safe sex practices, since we're talking about HPV. Vaccinations, huge one. There's another thing to prevent HPV, but vaccinations is another one. These are all preventative steps. Now, when we move on up to the secondary prevention, these are screening things. Patients potentially already have cancer at this point, but we're trying to catch it early. We're trying to control it. We're trying to cure it, whatever we can do with it. That's our goal. So secondary prevention is going to be our pap smears and our breast self-exams and our mammograms, colonoscopy, our PSA tests, and our digital rectal exams. Now, I want you guys to think about a couple things. Well, first of all, our screenings, our secondary prevention, they don't prevent cancer, do they? No, they find it early. Now, if you have one type of cancer, do you still screen for others? Yes. If you've got breast cancer and you've just found out you've got breast cancer and you're 54 and you've never had a colonoscopy, by George, you need to have a colonoscopy. So yes, we don't stop screening for things just because we have cancer in one spot, because we can have cancer in more than one spot. So we're going to be doing these things. Some of them are yearly. Our digital rectal exam, stool wax. There's different things that they do, and of course the mammograms are going to be. Well, I'm just going to leave that one alone because they're really trying to change the guidelines on some of these things that they do, and I'm not talking about any specific age, so I'm just going to leave that alone. But it's something that we're going to do yearly up to every 5 years with the colonoscopy. If there's a polyp in there, or family history, or 10 if there's not. So anyway, that's secondary prevention. We definitely, if somebody's got a cancer, we definitely want to find out where their primary cancer is, because like I said earlier, if they've got bone cancer, that's typically not primary, so we want to find out where it came from so that we can move on to, I was trying to segue into tertiary, but anyway, that's, they've already got cancer and we've got to do something about it. I didn't put that on there, but you guys know what tertiary prevention is. So, consequences of cancer. We have to worry about thrombocytopenia, neutropenia, anemia. I knew that you guys would know what all of those things were. Now, bone marrow suppression is something that, we have to worry about. If we've got somebody that's got their bone marrow is suppressed, then we have to worry about their white count dropping, because where do cells come from? They come from our bone marrow. So then if we've got somebody with a low white count or neutropenia, we've got a bigger risk for infection, right? So what are we looking for with these patients? If they come in and we know they've got cancer, what are we going to be doing looking for infection? What are we going to test? Yeah, we're going to check their temperature. We're going to have them check their temperature. If their temperature goes up, hey, we need you to come in. We're worried about you having some sort of infection. So those are going to be things, teaching points that we use when we see these patients. Now, I do want to talk about, under consequences of cancer, I know that I'm on that next slide, but I do want to talk about some testing just because I didn't throw that in earlier. Now, a patient, let's say that the patient has lung cancer. We are going to have them getting a liver scan, right? We want to make sure that it hasn't metastasized to the liver, because that would change their treatment. There are some sorts of tests that we're going to do that aren't just traditional ones, that if a patient has cancer in a certain area, we always worry about liver metastasis and bone metastasis, because those are really common sites of metastasis. So I want you guys to be thinking that that's something that you may have to do or may have to, look at. So I'm sorry I'm throwing that in after the fact, but anyway. Now, purpose of cancer treatment. We're trying to get rid of it, right? That's our main goal. We want to keep it from metastasizing. We want to keep the patients as comfortable as possible, because we don't, the side effects and symptoms that they have from it is not really good. And of course, once they're to a certain point, it may just be about the quality of life. That's the sad but true part about it. So, we're going to talk about some different things that we can do as far as cancer treatment. Chemo, radiation, surgery is obviously a thing. Now, there are different things, like there's hormone therapies that can be used. Most of the time that's on the male cancers, they're used a lot more. They'll give them estrogen if they've got prostate cancer. So that's another common thing that is used. So, anytime we're giving men estrogen, there's some symptoms that we think about, and we don't want them to get blood clots and all those things. So, hormone therapy is a potential cancer treatment. Interleukin-2 therapy is also as well. Anytime you give interleukin, there are a lot of side effects from it: fever, chills, rigors, and you just have to treat the symptoms with these things. Anyway, those just hit me as I was looking at it, so I wanted to talk to you guys about that. Now, surgery, of course, we try to, well, here's the deal. Most of the time we're doing a procedure to get we need some tissue or cells out because we need a biopsy. So we're either trying to diagnose or cure, or, surgery may be to remove the mass, or surgery just may be to make it smaller so that the patient doesn't have symptoms for it. Surgery may be a reconstruction. A patient goes in and has a mastectomy, and then they turn around and do, put well, I mean, they may not be putting an implant in at that time, but, they may go in later and do an implant, or they may just be, just trying to do a scar revision, or all those kinds of things are different surgeries that are possible. But anyway, the goal of it is, if we're having surgery to remove the cancer, of course, we want to remove the tumor, and we want a clear border around it. We want that clear margin of tissue around it, just so that we know that we don't have any cancer cells in that border. And of course, depending on if it's spread, remember our T&M, they may have to have some lymph nodes removed, or some tissue around that area removed as well. Now, when we're talking about radiation, I've got, the purpose on there for you guys. Of course, it's to destroy cancer cells. And the thing about radiation is it's not as systemic as chemotherapy is. So, most of the time the patients have less side effects, because you really only see side effects in the tissues that are being irradiated. Now, we give it in a series of divided doses because research has shown that more cancer cells are killed if you give it in smaller doses over a longer period of time. Now, I've got on there the two different kinds, the brachytherapy and the teletherapy. Of course, teletherapy is just the beam treatment, and then brachytherapy is the radiation implants, and so those are inside the patient. So we're going to talk about those as well. Now, of course, as you guys know, high doses of radiation causes cancer as well. So safety is really important for patients when we're talking about radiation. Now, if we're talking about the brachytherapy, and remember I told you guys that it's in the patient, you guys can see the list of things there. Now, if we've got somebody that's pregnant, do we want them coming in? No, we don't want them exposed to radiation. We also don't want, we don't want one nurse taking care of 5 patients with brachytherapy, because that increases her exposure to radiation by 5-fold, right? So it's going to be that the nurse really needs to only have one of those patients at a time, because we want to reduce her exposure. That's our goal. That's why we only let patients in for 30 minutes at a time. We're trying to reduce that. Now, remember, you never touch an implant. We're always making sure that sucker's in place and that it hasn't come out. But if you do, you're going to pick it up with tongs. Never pick it up with your hands. Always wear personal protective equipment. It's one of those things that safety is of the utmost key when you've got somebody that's got these radioactive implants. Whether we're talking about prostate seeds or, we could talk about the iodine-131 injection. Now, with the iodine-131, these patients, now this is an unsealed isotope. This is not a sealed one. But the patient gets this injection, and it is excreted in the urine and feces. So they're not going to be, we're going to have to be really careful with these patients. For 3 days, they need to use their own bathroom. Nobody needs to share a bathroom with them, because we don't want them to get exposed to this radiation. Of course, you have to flush the toilet extra. There's lots of different things that go along with that, but I wanted you guys to think about that. Now, typically we use these, the radioactive implants for prostate cancer, and I talked about the prostate seeds. That's a really common one. They can be used in the brain, tongue, lips, lung, breast, esophagus, vagina, cervix, endometrium, rectum, and bladder. So those are common sites for that. Now, anytime we're doing our patient education, now, if we're talking about, I've switched on to from the brachytherapy to the teletherapy, but we want the patient to, obviously we want them to bathe, but we want them to be very careful and just, use soap and water that's really mild. We don't want them scrubbing their markings off, because they're going to come in for their radiation treatments, and the doc is going to mark them up, and they're going to have Sharpie marks on them. And that's how they, because they're coming in every day for a treatment most of the time, 5 days a week. And we don't want to wash those markings off, because that's what they use to go by each time. So that's really important to tell the patient, don't try to scrub these off, because it takes a long time to remark those. So we want to keep them on as long as possible. Now, head and neck cancers are some of the worst ones, because radiation is really tough. It dries out the skin. I mean, most of the time these patients just have big flakes coming off of them. So I mean, we want to protect the skin as much as possible. They're what they're going to do, we're going to have to tell the patient, you need to talk with them over at, well, I'm used to saying Carti, but wherever they're receiving their radiation treatment, and ask them, what to put on it, because they will give some suggestions or prescriptions of different lotions or ointments or things along those lines, but that's not going to be something that they put on before their treatments. Some of those things can cause burns. So the patient does not need to use these before treatments. They'll go home and use them afterward. But, that's something that you really need to think about. If we're irradiating the mouth, throat area especially, a lot of times it really messes with their salivary glands, and these patients don't have any spit. So, that's going to be one of those things that they may have to take frequent sips of liquids. There's some artificial saliva that you can use. It's really weird feeling. It's gross feeling, but still, that's something that can be used. Now, these patients have been irradiated, so they have essentially like a sunburn would be. So they definitely don't want to be out in the sun because it will cause a burn. And of course, heat exposure is never good. So you want them to wear really comfortable, soft clothing so that it doesn't irritate that skin. And anyway, we're going to talk a little bit more about some side effects in the next one, like xerostomia. It's dryness of the mouth. And I've got a slide in here telling you guys about some things that they can do for that. Now, side effects, most of the time, they have an altered taste sensation. These patients, you always think about everybody being sick at their stomach and stuff when they're getting chemo, but and not eating and losing weight, but it happens with radiation as well. A lot of times things don't taste as good, and so they don't want to eat as much. Of course, sometimes difficulty swallowing, and some of that can be because they don't have enough spit in there. So here comes our treatments that we can do to help with that. Now, I put fatigue on here. Most of the time, patients go in and they start their radiation, they're like, woohoo, I'm feeling pretty good. But usually about 3 to 4 weeks after they start with their radiation treatments, they start getting a little tired. So they need to know that this is one of those things that can happen. Of course, you can have some skin changes and some scarring from it. And of course, if you're irradiating the head, that you can have hair loss from that. Tooth decay is something that can happen as well, and anorexia. Radiation just alters the blood flow to the capillaries, and so you have the red, dry, scaly skin afterward. And so we're really looking for skin breakdown on these patients. Now, all of these side effects, we talk about quality of life, and if the patient is miserable, then they're not going to want to complete their treatments, whether it be chemo or radiation. And so our goal is to try to do symptom control as much as possible. Now, also, we're worried about anemia and neutropenia and thrombocytopenia, which we talked about earlier. So we're going to be instructing the patients and their family on what to be looking for as that goes. Now, I've got some mouth care for xerostomia. This also applies for mucositis as well. Anytime you've got that irritation in the oral cavity, you don't want to use mouthwash because it irritates. And alcohol is a drying, it dries as well. So that's definitely an issue. Now, we want to do mouth care after meals and at bedtime for sure. Chemotherapy. I did list at the bottom of the slide the different types. I mean, you guys, I know I have been doing that in your farm, and I did not go through and put any, ask you any specific questions about, well, this drug is an anti-metabolite. I didn't do that. Now, of course, when we're talking about chemotherapy, we're trying to cure the cancer and we're trying to increase their survival time. I mean, that's what we're trying to do. Now, most chemo, it will kill the cancer cells, but it will kill normal cells as well. So, the patient has a lot more side effects. And so chemo destroys really rapidly dividing cells. And so, we have a lot of other cells that divide really fast, like our sperm and our, things along those lines. we have to worry about fertility issues. So, I really want, your patients and you to think about, it may be somebody with this may need to save some eggs or sperm or whatever. So, those are just really important things to think about. Sorry about that. Anyway, a lot of patients will have, hair is a big issue, and so they lose their hair. So it's really important to talk to your patients about things up front. I always talk to them beforehand about their wig situation. Some people don't mind not having hair. Some people want hair. Some people want the exact same hair as they have, beforehand. So, it may be that they need to go and get their wig before they ever lose their hair so that they can get the exact hairstyle, things like that. So I want you guys to be thinking about that. Yeah, I think that's about it on that one. Okay, so let's talk a little bit about chemo. Now, anytime you give chemo drugs, you are going to have to be chemo certified, right? You're going to be having your gear on, your personal protective equipment. Most of the time, places that give chemo, they've got their you have to have a special hood that's fitted to the outside. There's a lot of issues, safety issues that go along with giving chemo because it's toxic if you touch it. So you really have to be careful. And, you're going to tell your patients that as well. They're going to ask you, have you got on gloves to protect yourself or to protect me? And this mask, if you come out all donned up in all of this gear, they're going to think, oh my gosh, what's going on? So you really need to tell them the purpose of that. And that, if I get it on my skin, then I absorb it as well. So it's to protect me as well. So that way that they don't get, quite so nervous about it. Now, the big thing with chemo, we're usually giving it in a peripheral IV. Some people do have ports. Some people don't want ports. So, we give it through the IV. Now, this stuff is extremely toxic to the skin. And the best thing that we can do is just prevent it from happening to the patient, extravasation. So, we definitely want to make sure that the IV is patent. We're going to be doing a lot of things to try to make sure that, we're going to be checking that IV frequently, every 5 to 10 minutes, and make sure that it is patent, because I've got a picture in here, and it's actually next, so that you guys can see what happens. I mean, that's not a bad case. I've seen it a lot worse, but it is terrible, terrible, terrible on the skin. So, be really cognizant of that. You're going to make sure that you get a blood return. All of these things to make sure that this sucker is in place is what we need to do before we give this medicine. I'm going to flip on to the next thing. So let's go on to side effects of chemotherapy. Now, I've got a long list there. Now, I want you guys to know what nadir is. NADIR is the point where the lowest blood count is reached. And that's usually about 7 to 10 days after they start their treatment. Now, at this point, they are more susceptible to infection than at any other time, right? Because they are at their low point. So, really, really high risk for infection at this time. Usually their absolute neutrophil count is below 500 at this point. So, we're really looking for things. We're going to be having them check their temperature. If they have any signs of infection going on, we want them to get in there, call us and come in, or call or come in. So I want you guys to think about that. They're at their low point. So we really, don't want them babysitting the grandkids or, things along those lines. Don't go out to Walmart. Of course, most of the time when they're at this point, they don't feel like doing anything anyway. But I have seen some people, especially that live alone, that are really headstrong, and they're going to do what they're going to do anyway. But, we got to protect them as much as possible. Now, I've got all of the things listed there. Now, think about if a patient, I want you guys to go through your side effects and think about them. Now, of course, with anemia, a patient, their red blood cell count is going to be down. So what do red blood cells do? They carry oxygen. So they've got a lower oxygen carrying capacity to their blood. So they're going to feel tired. All of these things I want you guys to go through. Cachexia, cachexia. That's what I'm trying to say. Cachexia. I couldn't spit it out. Cachexia. That's that anorexia, that wasting away. All of those things. Now, 80% of patients that have cachexia, they're going to die of cancer. So, we want to try to prevent this and treat it early. We may have to do, if we're watching their weight, right? We're looking at them. We're looking at muscle wasting, in our assessments. We may have to start them on nutritional supplements if we recognize that something's going on early. Enteral feedings, all of these things are possibilities. So as you guys go through there, the hair loss, we expect that. You're going to have to do some extra teaching on that, extra support. Oh, you look great. If somebody shaves their head or somebody gets a wig, all of these things I want you guys to be thinking about. Nausea and vomiting, pre-medicate before they come in for their chemo treatments. Make sure that they're taking it afterward. If they've got sores in their mouth, give them some of the tips that we had listed back there. Okay, well, don't eat spicy hot peppers. Don't use mouthwash. All these things are really bad on these sores in your mouth. So, all of these things as you go along, I want you guys to be thinking about what you're going to do as nurses about it and what you're going to be looking for. Now, the interventions in chemo, of course, we're going to be looking for side effects. We're going to be looking for toxicities. We're going to hold it if, there's an issue going on. If we've dropped them out and they're, they have no immune system, they're so anemic, we may be holding their treatments. So I want you guys to think about these things. The best thing that you can do is teach patients ways to prevent infection, because that's going to be huge. They're not with us all the time. Now, if you're on the floor, they may be with us for a little while, but if you work in an outpatient or you work in a doctor's office, they're going to be in and out. So you have to do this education so that they know what to do when they're not with you, because we're not going to be there with them all the time to protect them. We have to teach them how to protect themselves. So, we've really talked about most of the other things. Support groups, I put that on there. Now, I do want to say, while support groups are great for the patient, they are great for the family as well. So, I really want you guys to be thinking, this is a there's a lot of factors, multifactorial issue. You've got the patient, but you've got their family as well. So be thinking about that as you're taking care of these patients. Also, patients do experience chemo brain. They can't concentrate. They forget things. They have a hard time learning new information that you tell them. So that's the reason why it's important to have family there with them when they come in for their visits, plus to drive them home. A lot of them have a lot of side effects and stuff. Now let's move on to neutropenic precautions. And I know that you guys all know this, so I'm not really going to go over it a whole lot. Again, don't go to Walmart. Don't share your toothbrush with your 5-year-old who's had strep throat. Stick your toothbrush in the dishwasher every day, or stick it in bleach and rinse it out really good before you use it. There's so many things that you can do. But of course, the low bacteria diet, that is something that you guys will need to know. All that is anything with low bacteria. It's no fresh fruits or veggies. You don't want raw stuff because it has bacteria on it, because it's been on the ground. It's been grown in the ground. That's what I meant to say. And what's pooped on the ground, and what's in fertilizer and all that stuff. It's bacteria. So, we worry about E. coli and all of those things. So that's the reason why we cook stuff. Our immune system can handle it. All of us that don't have issues with that. But somebody that's immunocompromised can't fight off the infection. So we just don't need to take it in. We need to cook it first. So thrombocytopenia, I've got the list of things there, because you guys know that we're really worried about any bleeding. So now we're going to measure that abdominal girth daily. I got my D in my anyway, never mind. So anyway, we're checking because we're making sure that they don't have any bleeding, the blowing the nose, rectal temps, all of those things. We're looking for bleeding. Now, I went ahead and added photodynamic therapy in here. It doesn't talk a whole lot about it. It doesn't talk about it in the book, but that's just one of those things that a lot of people have these days. So I went ahead and just stuck it in here. But it's used for a lot of different things. Skin cancers, well, not melanomas, but anyway, I just went ahead and put it in there so that it's just a laser treatment that they can use, and I just wanted you guys to see what that was and what it involves, because you will probably be seeing patients with it. Now, with the photodynamic therapy, I mean, they're sensitive to any kind. I mean, it's like with the radiation, and I talked about it. It's kind of like the skin is sunburned almost. They're very sensitive. I mean, you can put a pulse ox on them and leave it on there, and I've seen somebody with really bad burns after it. So that's the reason why I stuck it on there. So a pin light can cause burns. They're very, very sensitive. So you definitely want to turn the electronic equipment away from the patient. And we always consult a pharmacist with this because we want to make sure that they don't have any interactions with their drugs and stuff. So anyway, there's a lot of medications that cause sun sensitivity and different things and GI upset. So we just want to make sure that we cover all our bases. Now, on the oncologic emergencies, of course, sepsis is something that we see, and of course, it's very serious. Because patients can die from sepsis very quickly. The DIC, disseminated intravascular coagulation. I want you guys to think about this. Now, we've got these clots going on. So, the patient has pain and, all of these things. Like, I mean, look at some of those symptoms, like stroke-like symptoms and shortness of breath, like a PE would be. And, I mean, just depending on where it happens to be. But if you've got a patient with DIC, I want you to think about it. If it's in there, if they've got a clot in their leg, are we going to feel a pulse below the side of that clot? No. It's just like with a DVT. We may not see a pulse. It's going to hurt. We may see modeling. So as you guys are looking through this, I want you guys to be thinking about symptoms that you're going to see with these things and what you're going to do about them. Now, I'm trying to think if there was anything else on that I was going to tell you. Oh, no, probably not. I think I've pretty much, I was trying to look at the test as I'm talking here to see if there's anything else on there that I didn't cover. But I think that I've got most of it. So we'll just keep on moving on. And I've got the hypercalcemia, the superior vena cava syndrome. So, I want you guys to look at this. Now, tumor lysis syndrome is going to be one that you need to know as well. We have hyperkalemia. I almost said hypercalcemia, and I'm like, that's not right. Hyperkalemia and hyperuricemia can be some of those things. So I want you guys to think about, what do we see with a patient with hyperkalemia? We're going to be looking at the heart. We're going to be looking at all these things, right? But patients, we want to prevent this. So the best thing that we can do for our patients is to have them push fluids. I mean, it may be in an IV, it may be just having them drink, but we want them to consume at least 2 to 3 liters a day. We have to be very careful with these patients if they've got another heart issue, if they've got heart failure, anything along those lines. It can really pose a problem because we don't want to put them in to heart failure if they don't have it. So it's a delicate balance. So you really have to be careful with that. So, but pushing fluids is one of those things that is really important for these patients. Now, I went ahead and just stuck a slide in there about bone marrow and stem cell transplants and gerontologic considerations. These are all things that we've talked about already, but I went ahead and stuck them in there as well. I think that's about it, guys. So, just read over things, and I think that you guys will do great. And now, this test, a lot of it is common sense things. I just don't know how to say it other than that. I mean, you guys know you're going to have some drug calculations. I've told you some things that are going to be on there. A lot of this is common sense things. So I want you to think through it. I want you to think through each question before you take the test. And I think that you guys will do fine. Just, use your noggins and don't overthink. because you can make it really hard on yourselves when you overthink. Of course, I don't want you to underthink either. There's just that fine line, but just think about, as you're going through and studying, look at the symptoms and, well, geez, if this patient's going to have nausea and vomiting, what might I do for them? And, like I said earlier, pre-medicate them before their chemo. And, you don't want to go in and if they're in the hospital and they've just had chemo and they have nausea and vomiting, you don't want to give them a burrito dinner for, or whatever. So all of those things are things, that are common sense things that I want you guys to think about. We're going to do something lighter for them. If they're fixing to vomit, we probably want to give them clear liquids or, give them some pudding or some crackers or, all of those things. A lot of this stuff is common sense. So I think that you guys will do